Hello and good evening, everybody. Welcome to the webinar of the functional section, which is on how to start a functional service. My name is Krueger. I'm a functional neurosurgeon working at Queen Square in London, and I am here with my two co-hosts, Michael Hart and Franziska Schmidt. And we have two speakers, Dr. Honey and Dr. Catherine Moran. And I will hand over to Franziska, who will tell you a little bit about what's going to happen tonight.
Hello, everyone, and good evening. It's a pleasure to be here and to be a co-host of the webinar, How to Start a Functional Service. I would kindly ask to, if you have any questions, please use the Q&A box and ask your questions in the Q&A box, and we will take care of them for sure after each talk. And I would like to hand over to my co-worker Mike Hart. He works at St. George's in London.
Thank you, and good evening, everyone. So I'm entirely biased, but functional neurosurgery is an absolutely fascinating area of neurosurgery. We get to deliver interesting treatments to patients and make them better. Part of the satisfaction is working in great teams. We're always learning from people, and part of the success is we've got very good pathways in being able to select out patients and treat them well. However, that does make the services quite complex, and then setting one up becomes somewhat challenging. So that's going to be the focus of today's webinar. So moving on, I'd like to introduce our first speaker, Ms. Catherine Moran from Dublin. It's an absolute pleasure to introduce Catherine, who's a good friend. And it's actually very easy to introduce Catherine because she's got her own Wikipedia page. Now, I won't read out all of this, but some of the highlights from this are that, well, first and foremost, she's the first female neurosurgeon, not just in the Republic of Ireland, but I believe the whole of Ireland. She's done multiple fellowships, both in the UK and abroad in the USA, and these include not just functional neurosurgery, but complex spine surgery as well. So she's a true polymath. And for those of you who don't know, Republic of Ireland isn't part of the UK, although it's our only land neighbour, so it's right next to us. And for a long time, it didn't have a functional neurosurgery service, so the patients were stuck, and they came across, and that's until Catherine came along and set up the functional neurosurgery service in Dublin. So I'm really excited to hear this, and thank you very much, Catherine.
Well, thank you, Mike, for the intro. So I'm a consultant neurosurgeon, and I, along with my colleague, Professor Richard Walsh, movement disorder neurologist at the Dublin Neurological Institute, run the functional service here in the Republic of Ireland. And I'm just going to share my screen, if that's okay. So this is kind of a tale, as you mentioned. There's the Northern Ireland is under the NHS, the British Health Authority, and the Republic of Ireland, our health authority is the HSE, or the Health Service Executive. And that kind of comes into the play of the start of the DBS service here in Dublin. And the service is run between two of the major hospitals in Dublin, the Dublin Neurological Institute at the Mater, which is where Professor Richard Walsh is based, and the MDT team. And then the surgeries take place in Beaumont Hospital, the National Neuroscience Centre, where I am mostly based, but I do clinics in the DNI. And as you mentioned, prior to the setup of the service here, we were lucky enough to be able to refer our patients to three stalwarts: Professor Aziz in Oxford, Stephen Gill in Bristol, and Marwan Hariz at Queen Square. And our patients came from to the various centres from the 1990s till about 2012. And we generally sent approximately 9 patients a year for deep brain stimulation surgery. They also generally had their programming done post-op there and their preoperative assessments. So I worked with Stephen Gill, and we had patients coming from the Republic, which was difficult when you have advanced PD, getting flights over, and if there's any troubleshooting that needs to be done with programming, coming back and forth, or an IPG needs replaced in a hurry. There was a lot of logistical burden for patients. But the service that they were given was excellent, and they're still on our books today. And now they have the local service. So in terms of the legacy and lead-in, this service was really led by Professor Tim Lynch at the Dublin Neurological Institute. He founded the institute, and he was the main referrer initially from Ireland to the UK through relationships with all the centres that I spoke about. And he really worked tirelessly in terms of politically and within the HSE to set up a service here. And he was helped by, this is our former Minister for Health, whose name is Leo Varadkar. He went on to be our Prime Minister, or Taoiseach, and he had a role in bringing about this service also. And he himself is a doctor, so I think that helped with our requests. So a little bit of terms of a timeline. In 1997, patients were being referred to the UK via a treatment abroad scheme, which was quite a clunky bureaucratic part of the HSE, requiring a lot of committees to okay a funding for the patient to be treated and implanted in the UK. And over the years, in 2012, we had the initial report that looked at the feasibility or viability of a DBS service in Dublin, which was not positive. Then in 2014, Tim Lynch and also the centre in Belfast did not give up, and they requested a specific Oireachtas committee, which is a parliamentary committee on health in Ireland, to look at the question again. In 2015, we eventually got support for now an All-Ireland service, which had the surgeries being performed in Belfast and patients coming back down to Dublin for programming. In 2020, then we had the setup of a DBS team at the DNI. And then I was appointed after this to perform the surgeries at Beaumont Hospital, and the first surgery was performed in 2021. So initially, as I mentioned, in 2012, the Health Information and Quality Authority in Ireland published a report examining the feasibility of a DBS service in Dublin. And they were not supportive, and most of it was because of the capacity of neurosurgery in Beaumont Hospital. At the time of examining, and unfortunately this is probably still true, there were 532 patients awaiting neurosurgery. 40% of them were waiting for longer than 6 months. So they felt that one of the main reasons for denying it was we didn't have capacity within Beaumont for a new service. What they concluded, they did an economic analysis comparing the treatment abroad scheme to a national DBS service, and that it would cost more per patient. Also, part of our population, about 45% of patients here in Ireland, or of the population, have a private health insurance, and they were also getting covered to go to the UK, so that would add cost if it was brought back here. And they gave an overall figure that it would be 1.8 million in the first few years, and that wasn't a runner. So we were stopped in 2012. But then we had basically a lot of tenacity from Professor Lynch, who invited the then Health Minister, Leo Varadkar, to the Dublin Neurological Institute to meet patients who had been implanted for Parkinson's disease and tremor. And there was a lot of the patient advocacy groups who helped to lobby as well and promote this treatment. And he met 3 patients who were initially had their systems turned off and then turned on in front of him. And this, he just found it quite compelling. And from then we began to get momentum, albeit from 2015, to have a service here in Ireland. So in 2014, both the centres in the Mater Hospital in Dublin and the Royal Victoria in Belfast came together to lobby this Oireachtas committee for a joint national service. And at the time, post the Good Friday Agreement, other services had been developed for cross-border cooperation, such as the biggest service would be pediatric cardiac surgery, which the service was shared between Northern Ireland and the Republic. And in 2014, the patient lobby groups with both centres put an application to the Oireachtas Committee saying a national DBS service would result in an increase of number of patients being able to undergo DBS from approximately 13 to 19 a year. We were conservative. We didn't want to scare any politicians. And the potential benefits, outlining the benefits for logistic and finance for patients, and improve continuity of care and reduce administrative burden. I liked how they phrased it. As things stand, deep brain stimulation is not available in the Republic of Ireland, and this is unusual by international standards in comparison to other developed nations of our size. And that's how it started. And as I said, they highlighted the travel barrier costs, reduced post-operative programming visits, hardware malfunction, IPG depletion, and then the bureaucracy of the scheme that was in place at the time. So in 2015, this parliamentary committee responded, and they responded positively to the benefits of an all-island approach to deep brain stimulation surgery. They said that at that stage, they proposed a north-south collaboration. At the time, the surgeries with Neil Sims and Gavin Quigley were being performed in the Royal Victoria in Belfast. So the patients had to travel at least within the island, and they would undergo their primary implant there and then have their workup and assessment closer to home in the DNI in the Mater. And then in the medium term, however, the committee also advised that the approach would provide a sustainable the population of the whole island for 2 surgical centres, both in Belfast and in Dublin. So that's what we gained momentum then for a surgical service in Beaumont. So from 2015 to 2019, our primary DBS implantations were performed at the Royal Victoria Hospital in Belfast. And then in 2020, a full DBS team, and I'll outline who's on the team, began in the Dublin Neurological Institute in the Mater, and then the first DBS surgery in Beaumont Hospital in 2021. And this is my colleague, a bit of a grainy picture, Professor Richard Walsh. He started the service in the DNI, but it wasn't great timing in terms of any new service in healthcare. In 2020, our main challenges were the COVID pandemic and the change in resources that we all have to pivot to. Other challenges was, although the Oireachtas Committee okayed the service, they didn't give any money for it. So that had to be found here and there. So we then had to apply to the HSE, the Health Service Executive, as in the NHS equivalent, for actual funding. And then another slight barrier is that the 2 centres are in separate places. The DNI, you can see here in a little map, when there's absolutely no traffic, it's 18 minutes from there to Beaumont Hospital. So our business plan, which we wrote in 2020, outlined 3 different phases in terms of how many patients we wanted to treat surgically per year, increasing from 45 to 65 roughly per annum. At the time of the COVID pandemic, DBS surgery stopped at the Royal Victoria in Belfast, and unfortunately haven't restarted, but are due to do so for patients in Northern Ireland. They're currently traveling to the mainland UK, such as Liverpool. But we outlined a 3-phased plan to the HSE for funding. Currently, the team, me in Beaumont Hospital, I also do complex spine surgery, general neurosurgery, so 30% or 1/3 of my operating list goes to deep brain stimulation. I also have a clinical nurse specialist, a former senior ICU nurse who joined the team. We have since then had a fellow in functional and epilepsy neurosurgery who work with me and my epilepsy colleagues. We also have an MD student funded by the Royal College of Surgeons. And then in the Matter and These team was earlier than me. Currently, Professor Walsh is doing this as a half whole-time equivalent position, and his other half is a general movement disorder neurologist in a separate hospital. So it's a big service to carry for half-time, whole-time equivalent. We also started with 1 senior clinical nurse specialist in DBS, physiotherapist, a whole-time neuropsychologist, speech and language therapist, and an administrator. And thankfully, since then, we've had a 2nd clinical nurse specialist, a fellow in neurology who's industry funded, and we're hopefully in the next month or so going to appoint a 2nd consultant neurologist for the DNI to help our throughput. Our clinical nurse specialists perform the Levodopa challenge. They've incorporated Kelvin computer vision scoring platforms for the UPDRS Part 3. They perform CAPSID at 6 months, 1 year, and 3 years. They run a 5-day-a-week helpline. They also participate in programming along with Professor Richard Walsh, who generally leads the primary programming sessions, and also a lot of patient education. We have a whole-time neuropsychologist who works directly with the team, who performs assessments. Usually it's a 2-day assessment with physiotherapy, neuropsychology, speech and language, and the DBS nurse specialist prior to our MDT. He does the Wessler memory scale, the MDRS, the scoring for mood and anxiety. Patients are generally followed up with them 12 months post-surgery, but earlier if we have any concerns, or also if there's any functional overlay with the patient, that we have a neuropsychologist with us in the team is very important. We also have physiotherapy who use wearable devices, have our patients use wearable devices, perform a very in-depth analysis of gait assessment, which we would, for all essential tremor and Parkinson's patients, they don't, and they routinely see the dystonia patients as well. And they are based, as I said, at the Dublin Neurological Institute. We also have speech and language therapists based directly with our team who do all of the main SLT screening, and if needed can provide us with video fluoroscopy or FES if we think a patient requires further workup. So that team was in place in 2020, and then I was appointed later on in 2020, but had to set up the physical service of a in terms of theater equipment. There was a ROSA robot there, which was being used for SEG, which was recently acquired. So I used that, but I needed a lot of buy-in from neuroradiology, neuroanesthesia, my medical physicists, who were a great team and really kind of made all the widgets talk to each other in terms of what software platform. And we also had a lot of industry help from Zimmer Biomet for the ROSA, FHC Brain Lab, which I use for preoperative planning, and now post-op with the Guide XT, and both Medtronic and Boston were involved in the setup. So from 2020, our original numbers were that because we were maybe not sending enough patients for the previous 15 years, there was probably already about 300 eligible patients as per population in the country. Initial referrals in 2020, there was 55, 36 were referred at the MDT to DNI. At this stage, I hadn't been appointed, then the surgeries hadn't started yet. So before I started, we had 70 patients awaiting DBS, which is a big number for primary implantation. And then in terms of the surgical procedure, I performed the surgeries asleep with on-table O-arm verification of lead placement using brain lab software for planning, and also during surgery for fusing our intraoperative scans to check electrode locations, and then for post-op for Guide XT, which is also relevant for the new Illumina and Cartesia X leads for Boston. This is a picture of our medical physicist, Jessica. We had, 3D printed heads of our first patient, one with the skull on, one with the skull off, with the STN, that we did multiple run-throughs for the radiographers and theater staff who'd never performed a DBS case before, to get our workflow really quite succinct before starting the first surgery. So this took a little while. We also, Michelle Lefranc from Amiens in France, who helped develop the ROSA robot and used the same workflow as I was planning. He kindly came as a proctor for first surgery, and I visited his center also before. So a lot of moving parts to fit together to have a nice, clean surgery. Again, the O-arm and how we can get a good picture without having a artifact to check lead placement. So the demo overall, as we got our pieces of equipment together, and because there's no surgery before, there's no even legacy. So the microdrive fitting to the ROSA arm took a little bit of help from FHC and Zimmer Biomet to make the hardware work. And then our first surgery was in November 2021, and it's a small country, so we did get onto the national newspaper. This is Mr. McGinty with his sister in a national newspaper talking about his treatment. I guess because we had such a cohort of patients, this gentleman was dosing every hour and a half. He was in his 40s prior to surgery, with the extraordinary levodopa challenge percentage improvement. So we knew he was going to do well. So we were able to pick our very best candidates to start with. And this is some pictures, or this is some quotes from his newspaper articles when he was after his surgeries. He described having his severe PD, sometimes like your brain was trapped in your body, not paralyzed, but close to it. And since surgery, he walks 5 to 10 kilometers most of the days. At one point, he was completely off his medication, which my colleague, Professor Walsh, probably didn't agree with, but it's made a huge difference in his life. Then we're all on a high, and then you get your first complications. So this was about a year into the surgery, with a wound infection, and antimicrobial therapy and salvage surgery was unsuccessful, so required explantation. And what you learn from these complications, we changed our preoperative at-home antibiotic prophylaxis in terms of patients now get Hibi scrub for 1 week. Everybody gets MRSA treatment, mupirocin nasal ointment prior to surgery. And this has reduced infection. In terms of our surgical wait times, because I started off with 70, patients, we still had a cohort who were waiting longer than a year and maybe over 2 years. So we got specific funding to send patients to the Erlangen Pereira and the London Clinic for implant surgery and follow up in the DNI for programming. And this continues now for any patient who has private health insurance are given this option, which helps me in terms of capacity and not having a exponentially growing waiting list. So Erlangen is an honorary member of the Irish team. And the service to date. So between 2020 and July 2025, we had 449 referrals reviewed by our neurology team, Professor Walsh. 49% of them were then referred for full MDT workup. So about 220 roughly. And then to date, I've performed 65 primary DBS implantations in Beaumont. 78 have gone to Erlangen Pereira, so there's still a cross-country collaboration. Overall, we've done, these are just the numbers in Beaumont, about 80% PD and 84% of those are bilateral STN. For tremor, the target I use is a VIM PSA dual targeting and dystonia, 13 patients. And also we have a cohort of people requiring IPG changes, which can now be done here in Dublin instead of having to travel back to Oxford or Bristol. And in terms of the future timeline, we're hoping to increase theatre capacity in Beaumont Hospital with longer operating days so that 2 surgeries can be performed instead of 1. The possibility of starting a DBS service in our private hospital, which also offers cranial surgery. And then we also have an intraoperative MRI scanner planned for Beaumont Hospital, which would include focused ultrasound. That's about a 3-year horizon plan. And then a second functional neurosurgeon in Beaumont Hospital once there's increased theatre capacity. And then just a little quick video. We did have a TV show that was followed patients from Beaumont Hospital that last winter. And one of my patients appeared on it, including his surgery, and it's been quite useful for patients. Most patients who come to clinic now have seen it and know what I'm talking about when I describe DBS surgery. So I'll finish with a little snapshot of that.
The best way to describe Parkinson's is you run a marathon. I strap lead weights to your legs and your arms. I cover you in heavy clothing, drop you in the ocean, take you out until you go for a walk. You pretty much can't. It's not like you don't want it, it's nothing in the tank. I mean, you need the dopamine to tell your muscles to do stuff. And if it ain't there, no amount of willing is going to make it work. Your day is pretty much, you're planning everything around the pill. I don't know what normal is anymore. I take medication from 7 in the morning every 3 hours. So I go 7, 10, 1, 4, 7, 10. That's one set of medication I can take. The second set of medication I take is at 9, 12, 3, 6, and 9. So if DBS is successful, I do want to just be out of the house more and do more things. Even sometimes we go to a movie, go watch a football match in the pub. Having something you can aspire to do in life, that's the key, isn't it?
So we need within a millimeter accurate. And slow now. So we're at right frontal fiducial. That looks nice, actually. Definitely good. Cool. Continue. And I'll go fast again. So this is going to give us our entry point for the electrode. So we've inserted the electrode. So now we're going to make sure it's where we want it to be within a millimeter. Nice. Excellent. Great. So these are the cranial wires that we put into his brain. So we're going to just take them out here. This is the left brain lead, and this is the right brain lead. and we're going to place extension wires from here, this is the right ear, down into the pocket where his battery, like a pacemaker, is going to stay.
It's been about 4 months since I had my surgery. I'm feeling pretty optimistic. I'm feeling pretty good. In terms of the surgery itself, it went well. Once I got past the first few weeks of the stitches, the staples, discomfort, I've been feeling much better. Overall, I've managed to put on a few pounds, and it's reduced all the pain I was in. Didn't realize how much pain I was actually in until I actually felt what it was like not to feel like having pain. But I have to trust in the system. If I want to see results, I have to take a gamble out of it. Skip a pill, I'll still be able to have this device stretch the pill out. That's the objective. Surgery is not a silver bullet, but it's going to give me more of me back. That's what I just want. More of me. Lately, I've been able to get a little bit more of my mobility back. And now I'm not struggling as much. I'm still feeling a little bit off, but it's not like, boom, I'm thrown to the floor. I'm literally have to hobble to the bathroom. I'm literally able to do a bit better. I'm not quite an old man.
Okay. Well, thank you. I'll hand you back to
Thanks so much, Catherine. That's a wonderful talk. Terrific mix of politics, peace plans, finances. I've got to say, if you're thinking it's difficult setting up a functional service, it's quite another thing setting up the first in a whole country with all of that background to it as well. So if it's okay, I think we'll move on to our next speaker and have all the questions at the end. So some of the questions will be joint and complement. We can maybe have some discussion as well. As Franzi said before, questions go in the Q&A. And with that, I'd like to hand over to Marie.
Yes, so it's my great honor and pleasure to introduce our next speaker, Dr. Honey, who is a professor and head of the Division of Neurosurgery at the University of British Columbia. I could say a lot more things about him. The things I want to point out is that he has trained more than 30 fellows from all over the globe, including Michael, Franziska, and myself. That's why it didn't take us long to think of him when we organized this webinar. And he's been the only functional neurosurgeon in all of British Columbia for a very long time and has a lot of experience in how to set up a service. And he's going to talk about all of that. Yeah, he's a renowned researcher, a fantastic speaker, and a great teacher. So I'm very much looking forward to your presentation, Dr. Honey. Thank you.
Thank you, Marie. Thank you, Franziska, Michael. It's just a delight to be able to share our experience with your audience. And I'm going to try and share my screen and share. I think you can see what I see. And go to my... would like to see, oh, here. How's that? Starting a functional neurosurgery. So I live and work in Vancouver, and we started a functional service many years ago. Functional neurosurgery, as you know, can cover a wide variety of neurological conditions and treatments, primarily movement disorders, epilepsy, pain, and psychiatric conditions. And each functional neurosurgeon may have a different Venn diagram of their practice. And in Vancouver, my world has focused around movement disorders and pain. And I'm going to talk primarily today about movement disorders, although pain does come under the functional umbrella. I started functional neurosurgery a few years before Dr. Moran did, back in 1995. And that was a few years after the Leitinen paper repopularizing pallidotomy. And so we did about 400 pallidotomies in my career. And the basic knowledge to do a lesion in the brain is very similar to the basic knowledge required to place an electrode in the brain. And over the years, I have done over 1,000 DBS cases and learned from trial and error how and how not to do them. At the same time, I've had a big interest in facial pain, particularly trigeminal neuralgia, but some of the other unusual facial pains, and have had the delight to do over 1,000 MVDs and probably closer to 3,000 percutaneous rhizotomies for trigeminal neuralgia. And when you develop an expertise in pain, you tend to get the unusual cases. And so we've also done trigeminal nucleotractotomy, DRES, cordotomy for palliative care, nociceptive pain, and capsulotomy for what we believe is the pain of depression. More on that later. So in starting a functional neurosurgery service, the key is to bring a group or team of people together who have the primary focus of caring for your patients. And different services have different groups, but a common theme is that the group will have a neurosurgeon, a neurologist, a nurse, psychologist or psychiatrist, anesthesiologist, perhaps a fellow, and some research assistants. And I just want to go through the roles of each of those members of the team. So first is a neurosurgeon, and they would require specialized training to do DBS or lesions. And most of the younger functional neurosurgeons have done a fellowship. Some of us who started many years ago never did a fellowship, just learned the procedures on the fly. And there definitely is a learning curve for DBS or probably any other neurosurgical procedure. And it's probably, with plus or minus, around 30 cases before you're very, very comfortable. And that should be something potential fellows should think about when they are selecting a program to train in. What are your numbers? And you would like to at least get hands-on for, I would suggest, at least 30 cases. In Vancouver, we do about 70 a year. And it is important to recognize that functional neurosurgery, unlike some areas of neurosurgery, is always dramatically advancing in terms of the therapeutics and the range of patients that we can treat. And so when I began, there was no DBS. And so we are constantly involved in continuing medical education, CME. And a few years ago, there was no HIFU, high intensity focused ultrasound. And so the field is rapidly developing, and it behooves the surgeons who are in functional neurosurgery to go to meetings and continue to learn. What about the neurologist on your team? It is very important that they have specialized knowledge, and you will probably collaborate with different neurologists for different aspects of your practice. I am most familiar with the movement disorder neurologists, and there are 6 of them at UBC that I work with that are focused purely on movement disorders. But if you're going to do an epilepsy program, it behooves you to collaborate with an epileptologist. And if you are doing psychiatric surgery, you'd better have a very good psychiatrist, and similarly with pain. And the reason that it is important to collaborate with good neurologists is that they present you with their patients. And so in my experience, if I get a referral for DBS for a Parkinson's patient from a family doctor, the likelihood that that patient will go on to have surgery by me is actually quite low. They probably haven't optimized their medications. There are other options for them. If the patient is referred by a general neurologist, the likelihood of them having a condition that requires DBS surgery is about 50-50. But if they are referred from a movement disorder neurologist, the likelihood that they're going to require surgery is very, very high. And so with your time being very, very precious, it is important to have a flow of patients coming to you with a very high probability that they require surgery. And that's why it's important to collaborate with someone, a neurologist who is knowledgeable about movement disorders. I think Dr. Moran highlighted some very important facts, and that is at the beginning of your practice, when you are just starting out and the neurologist is trusting you with their very first patient, it is very important not to have mistakes. Early on in your practice, it is imperative not to have a complication. You must be exquisitely careful. After doing 1,000 DBS cases, if there's a complication, my colleagues just say, yeah, that's life. In fact, we've actually never had a death from our surgery. But if I was to, God forbid, have a death tomorrow, the neurologists and the community at large would say that is the price of doing sophisticated surgery. But if you had a death or a bad complication like a stroke in the first 6 patients, they're going to look sideways at you and not trust you with their patients. The second thing that was beautifully exemplified by Dr. Moran was if you look for really good successes so that you can show your colleagues the benefit of DBS. For example, that nice video. And I have exactly the same kinds of videos that even the layperson would think, oh my God, that's incredible surgery. When you turn it on, all of a sudden, it's like a Lazarus effect. They get up out of the chair and start doing jumping jacks. And so early on in your career, it's a good idea to capture that visually with a video because a video says, a picture says 1,000 words. And you need to educate your neurologists that they are not going to lose their patients to you. And I had trouble with this many, many years ago, that the neurologists felt that their income source would be depleted if I cured their Parkinson's patients. And clearly we do not cure them. We collaborate with our neurologists to improve the patient's life, but they still require a neurologist ongoing. I think the nurses are a fundamental and irreplaceable part of the team. It is far more important to have a good neurosurgical nurse than a very smart technician that knows DBS and electrophysiology. They provide an intraoperative companion, and they can also adjust the patients postoperatively. I would say convinced, it sounds too clever, but I tricked our funding agency into the concept that it was absolutely imperative for a DBS nurse to be in the OR with the patient. The truth is you can do the surgery without the patient, particularly if they're asleep like Dr. Moran. But if they're awake, they serve as a wonderful support person for the patient undergoing surgery. And then postoperatively, they really get to know the patient. What are your goals? How can we meet them? And they develop a personal relationship with your patients and can optimize their therapy based on that individual's needs. And that really can't be replaced. And I would say good neurosurgical nurse is an irreplaceable component of the team. And we have 4 nurses that are dedicated to DBS. The psychologist or psychiatrist. This is a bit controversial, because you'll often hear lectures on DBS by people who have big research teams, and every patient needs to go to a thorough neuropsychological evaluation. And I'm going to be a little bit controversial and say that's absolutely not necessary. We have access to neuropsychologists, neuropsychiatrists if we need them, and we will send our patients to them if we think that they need them. And I will follow their guidelines explicitly. But in general, the typical patient going for DBS doesn't need a PhD level neuropsychological evaluation. Now, I think that's just the truth. And so we will you need to recognize what the red flags are to send your patients to a psychiatrist, but I don't think every single patient needs to do it. And the reason why some of the recommendations are every single patient needs to see a detailed neuropsychological evaluation is because the people giving those lectures are the people that are publishing research on the neuropsychological changes of DBS. And our sort of take-home message is that you almost need a neuropsychologist to see any potential deficits in our DBS patients, reduced verbal fluency, for example. The patients don't come back and say that. There are complications, of course, but I think you definitely need access, but I don't believe it's mandatory. Take that with a grain of salt. It's a little controversial. We are doing DBS, and our electrodes are very close to deep limbic circuits, and so it can trigger neuropsychological changes in our patients. Absolutely. You reduce the dopamine postoperatively in an STN patient, they can get hypodopaminergic anhedonia. Never operate on a patient with dopamine dysregulation syndrome. And depression is actually the most important determinant of postoperative quality of care change. More than changes in your UPDRS-3, more than changes in your ability to move or time to movement. If you are depressed and remain depressed, your appreciation of the surgery will be dramatically reduced compared to if you come in normal and can recognize how good you've become following DBS. Anesthesiologist. So you will have an anesthesiologist, although you might not have control over who you get. But I will tell you that a neuroanesthesiologist is better than a general neurologist. Sometimes in DBS, the anesthesiologists feel that it's not a particular difficult case, just keep things going calmly, and they might send a junior colleague or someone who is not experienced because you're not on ECMO and all these sort of impressive cardiovascular challenging aspects. But the truth is, anesthesia during the surgery, and I do almost all of mine awake, is absolutely crucial in terms of reducing complications. And so the key with dealing with an anesthesiologist in your room, if I may say so, is communication is absolutely vital. They need to be able to feel that they can talk to you, and you need to be able to comfortably recommend what you want to them. And often our anesthesiologists are sort of separated by the curtain, and they are emotionally distinct from us. And so I try and create an environment in the OR where we're going to talk freely, and I will tell them respectfully what I need from them. Keep the blood pressure under 140. Don't give them any sedation whatsoever. But if you feel you need to, please don't hesitate to tell me, and then I will adjust my expectations based on whatever medications you have given. So they need to be able to feel that they can talk to you and not just quietly start adding ketamine on the other side of the curtain when they're trying to relax the patient. And then a fellow. The fellows are, I believe, they're really the driving force in academic productivity, crucial component to any academic functional neurosurgery. Usually, not always, but usually the staff or the professor knows what the problems are in the field, knows what the questions that need to be answered to move the needle in functional neurosurgery, and can present those questions and those ideas to the fellows, who then do the grunt work of actually generating the research and publishing the results. When you are selecting fellows and you are trying to increase your academic productivity so that people in the next generation can benefit from functional neurosurgery with new techniques, it's important to recognize that a bad fellow is worse than no fellow at all. And so how do you select them? The ultimate selection is a referral from one of your colleagues. So Dr. Moran mentioned that she occasionally, or they invariably, a long time ago, sent all their patients to Steve Gill, Tipo Aziz, and Marwan Haris. I know all those guys. And Steve, Tipo, and Marwan would speak to me casually at meetings and could say, would you mind helping to train this person? Or and my answer would be absolutely yes. And so one of the absolute pleasures of my job, as much as helping patients, is meeting fellows from around the world and locally and getting to know them very, very well over the period of a year. And I've had a delight. I've been very lucky to work with Dr. Krueger's heart and Schmidt, who all trained. And I would just add, which I just added a few minutes to my talk because of Dr. Moran, and I'm just going to move the picture over. Yeah, so Neil Sims trained with us as well, right around the time of the Olympics in 2010. And he was a fabulous fellow who has now gone back to Belfast. And then research assistant. So if you are going to do academic neurosurgery, and it seems to be a tradition that functional neurosurgeons are involved in academic research, maybe a little bit more than some of the other branches of neurosurgery. Certainly there's excellent research in all areas of neurosurgery, but often functional neurosurgeons have a deep neurophysiological interest in brain circuits, and we do have a duty to care not for our patients today, but also to care for the next generation, to drive the knowledge of neurophysiology and neurosurgery, so we can better care for our patients in the future. And we do have a unique access to the human brain in awake patients. And so because of the research coming out of functional neurosurgery, our field is dramatically advancing and the demand is going up. So just in Parkinson's alone, the population is aging, and the incidence of Parkinson's in each age group is also dramatically increasing. And so the demand in functional surgery is going up. There are new indications for DBS. HIFU has just come on as a way of lesioning, very popular for essential tremor. We yet to have a disease-modifying treatment in the world for these neurodegenerative treatments. It's all the DBS and lesions, they are symptom modifying. But eventually, we need to stop the course or progression of the disease, and we need to reverse it. And Alzheimer's is going to bury medicine in the next generation or two. The treatment of meningioma is lovely, technically delightful, works very well, but pales in comparison to the societal need of some treatment for the neurodegenerative disorders like Alzheimer's. And the treatment is probably going to come with gene therapy. Who is going to place those genes in the brain? It's going to be a functional neurosurgeon for sure, because of their comfort with stereotaxis and their interest in neurophysiology and advancing science. SSEG and LIT has transformed the treatment of epilepsy surgery. Who's going to do that? Functional neurosurgeons. And then probably as our techniques become more acceptable to the general population and psychiatrists, there's going to be a huge increase in the treatment of psychiatric conditions, OCD, depression, and a variety of other conditions. And that's all going to be done by functional neurosurgery. So take-home message. Make sure you collaborate. Pick out your good, smart colleagues. So I have a respirologist who happens to be a good friend of mine. And we talk about conditions, and this is a condition, it's a personal interest to me. Compression of the vagus nerve can cause intermittent vicious coughing and choking. And this lady has a trach because she's got compression of her vagus nerve. That condition would never have been discovered and cured without a collaboration between an unusual group of people, a neurosurgeon and a respirologist. And so when you are starting out your practice, it is very important to pick out potential collaborators, find out who the young, bright movement disorder neurologist is, and link up with them. You need to build a team. And really, you can't work as an isolationist. Very soon, you'll be overwhelmed by just the amount of work that you have to do. But in order to select the patient and do the surgery, so for functional neurosurgery to work well, you need to operate on the correct patient, and you need to operate correctly on that patient. And that needs a neurologist to refer you to the right patient and a neurosurgeon to do the surgery correctly. And so you cannot be an isolationist in functional neurosurgery. And you need to share your knowledge. And so these are in my heartwarming pictures for me where senior fellows in Vancouver are teaching a new, more junior fellow the techniques of deep brain stimulation. And I just highlight Michael Hart there as one of our fellows. And so I would say the take-home messages for starting a functional surgery service, the key is building a good team. And in order to do that, you need to be a collaborator. And then you will have the joy of continuously learning a subspecialty in neurosurgery. And it's one of the things that originally drew me to neurosurgery, the concept that I would have to be continuously learning over the course of my life, and that I wasn't doing an appendectomy and then I didn't know I could just do it over and over and over again without learning a new technique. And I've had to learn a number of new techniques in functional neurosurgery because the field is evolving. And so with that, I will stop sharing and thank you for your attention.
Thank you very much, Dr. Honey, for an excellent talk. Perfect, exactly what we wanted. And a great platform, I think, to kick off the discussion. And I think I'll hand over to Franziska, who wanted to take care of our Q&A box. And I can see there are some questions in there.
Yeah, there are some questions. So thank you very much, Dr. Honey and Dr. Moran. These were excellent talks. I really enjoyed both of them. And we do have a very interesting question from Moldova. I quickly read it out loud. So I'm currently the only fellowship trained functional neurosurgeons, which is very impressive. And I've been appointed to lead our national epilepsy surgery program. We already have a strong multidisciplinary epilepsy and movement disorder team, but we lack the technological infrastructure from both DBS and epilepsy surgery. In a resource-limited system where the government insurance doesn't yet appreciate the long-term economic and social value for functional neurosurgery, would you recommend launching DBS and epilepsy surgery as a combined functional neurosurgery package, or is it more realistic and safer to start with one program first to build credibility and justify future investments? And in the scenario, what would you consider the minimum essential equipment required to begin safely and sustainably? So first of all, thank you very much. This is like wonderful questions and many questions. So I will give the word to Dr. Honey and Dr. Moran.
Wow. Well, Dr. Andreska, that is a beautifully written and complex question. I think they're different programs. You can do epilepsy surgery with minimal specialized equipment. It's not particularly expensive, but DBS definitely is expensive. And how you are going to get your national service to fund a DBS is a long question. I will try and very briefly answer it. You need to know what the lever is that makes the person who decides if they fund you or not worry. So it's usually the Minister of Health, and the Minister of Health, you need to know what that Minister of Health cares about and what he's scared about. So let's just, between you and me, I presented my desire for a DBS program to the Minister of Health more than 20 years ago. They really couldn't care less about patient quality of life. Then I tried to present a business case to them. Hey, if I do DBS, I am going to put someone back to work. They are going to stop taking insurance from you and they're going to start giving you taxes. And if I can do that for a couple patients, I'll pay for the whole program. And I can keep someone at home safely and let their spouse go back to work. You're going to make money off of this program. And the Minister of Health said to me, all the tax revenue goes to the Minister of Finance. None of it comes to me. You're just going to cost me money. And I couldn't believe it. My jaw dropped that the Minister of Health was thinking, I don't want to make the Minister of Finance look good. So you need to get even higher to the Prime Minister or the Premier, and you'll never get their attention because you're small. And so What actually happened for us was patients got upset that they were waiting 4 years for surgery. Patients started getting on TV and speaking to their Minister of Health, and that was the kryptonite for the Minister of Health. He didn't want bad press. And so the month before, he said, where are you going to get the money from, Dr. Honey? Do you want me to take it from women's breast cancer or pediatric oncology? There's just no more money in the system. 1 month later, he said, okay, we're going to double your funding. And I said, well, I don't need it doubled. I need to go to 60 patients a year. That's what I figured out. I don't need to go from 35 to 7. I just need 60. No, we're doubling your funding. Okay. Why are you doubling? Well, you know why they're doubling the funding? Because it's a perfect soundbite on TV. We are doubling the funding for DBS. I am a great person, Minister of Health. And so that's how we got all our funding. But it's something you would never learn in medical school. With that, I'll hand it over to Dr. Moran.
Well, yeah, I think what Dr. Honey said earlier about collaboration, if you have a neurologist who will lobby with you, because they will have, I'm sure there's Parkinson's groups, even if they're a little informal, you know, you're going to have a population who's suffering from the disease and you have to just work with them. And that's how the Irish system got up and running. It was a lot of lobbying and kind of, you know, smart politics. And also sometimes starting off with a number cap. For example, saying, listen, can I do 10 of the most needing PD patients in 2026? And negotiating with the providers, Medtronic, Boston, Abbott, in terms of getting a service up and running that they would help you initially for a lower cost battery, IPG leads, etc., that you could, because that's your main expense. If you can get them on board as well, if you can partner with the industry to have a whole country get a new service along with the patients, but it takes a lot of effort and a lot of shaking the tree.
Can I just add? Oh, sorry. May I just add and highlight that? It's if you have a doctor and a neurologist lobbying, the bureaucrats can say you're just greedy doctors who want to do more surgery, get more money, but they can't dismiss even if you're on salary. They can dismiss you. They can't dismiss patients. So it's far better to have a patient lobby than it is to have a doctor lobby. And then the concept that Dr. Moran said about capping it, don't get scared. We're only doing 6 a year. Is good. So the people, wasn't me, but we tried to get, it wasn't me, but there was a service in Vancouver that wanted to get sacral stim for incontinence. And they went to the government and said, look, we can solve all the incontinence in the nursing homes. They can get rid of the diaper service. And it's only going to cost you, $10 billion and the government said, oh my God, you're going to be operating on 20,000 people a year. It scared them. And that introduction of sacral stim for incontinence took a major hit for about 3 years before they said, oh, no, we're only going to do, 6 a year. And then once you're in, you got your foot and you just do as many as you want.
Thank you very much. So Dr. Andruska, I had a small add-on question regarding the initial investments, which I think is worth to talk about too. So Dr. Andruska was asking, I will quickly summarize it. So if you want to start safely, what would be your recommendation in terms of the initial investments, in terms of what you need, like not the implants? So what's like the minimum to make the surgery as safe as possible?
Dr. Moran, do you want to?
Well, a frame, and if you go, depends on what you're trained on, but if a frame, and then trying to find, if you dig a little, you can probably get them secondhand, kind of around Europe. I'm just putting a little bit of, but yeah, to try and see if you can find equipment elsewhere.
And the truth is, there's more than one way to do DBS, right? Dr. Moran is doing it asleep with the robot. We're doing it completely differently, and they both work very, very well. And so the thing that I would recommend for Dr. Andriska would be link up with somebody, a friend, find a functional neurosurgeon that you trust and find out how they do it. And then you can get feedback from them even 7 years later when you have a difficult case and want, should I operate on this patient? What are your thoughts? Have a discussion with someone you know, and then follow their pattern, because that's not right or wrong. There's multiple different ways of doing it. And one of the joys of having a fellowship program is we now have a network of people who can ask each other, what about this rare stuff? And sometimes that's very, very nice.
I think it's certainly worth considering doing the surgeries asleep and just not buying an ION machine. Just a thought. And the other thought I had was, I know we're always talking about DBS, but we just had a visitor from China, and he was with us for one day, and he saw an RF thalamotomy and DBS, and he said, forget about DBS. This is so expensive. I'm gonna go back and just do RFs because we need something for tremor, and we can't afford the DBS stuff. So I think it's also worth thinking about doing simple RF lesions with all you need is this radiofrequency machine that a lot of centers have, no hardware, also no follow-ups, much cheaper. And it is so impressive. Whenever we have a new manager who joins the team, we get him to see an RF. And then we've got this patient with the tremor, and then you do chuck, and it's gone. And then they're so impressed, and they usually are very supportive afterwards. So I think maybe not necessarily starting with DBS, but doing radiofrequency ablation to get your foot into the door, something to consider as well.
Yeah,
I met
Alexander.
I can't remember his name. He's a Ukrainian neurosurgeon, DBS neurosurgeon. I don't know if
Costas.
anyone. Yeah, and if you could visit, maybe not visit him right now, but he does
hundreds, yeah,
and then does maybe 5 DBS for dystonia. So, an option.
Yeah.
Well, Alexandra, I'm very excited for you. I mean, it'd be great to have you back next year on the same webinar when you can tell us about setting up the service in Moldova. And Konstantin, I mean, he's right next door, so he might actually be quite good to visit. I thought Dr. Honey's point about not having any early complications is quite relevant to that question too. So I do a variety of things in my Venn diagram, DBS and epilepsy, and it's quite difficult to get into depth. And when you're starting off, you don't want to spread yourself too thin and trying to spin too many plates and setting up everything at once, because it'll be super busy setting up everything. So I think that's just something else to consider as well. But yeah, good luck.
It's doable.
May I ask the final question to Dr. Moran? So after you have been appointed, I think you said in 2020, and after you had you said almost 70 patients on your waiting list. So what was then the most challenging part for you? So you've been appointed, you had the equipment, and then what was for you challenging to get the service started and running?
It's hard to, we needed logistics in my hospital is the place is at 110 capacity at all times. It's extremely busy. And even trying to get an OR to do a run through with the OR, I had to use my own actual operating theater lists because they're all full all the time. So that was hard. And capacity is still our main issue in terms of, everything else really works really nice. If I could get another 3 lists a month, we'd be taken away really well. But that was difficult. Having people waiting is not easy. But the upside of that was, our first patients that we implanted were as Professor Honey said, were the wins. You know, I don't think I did a dystonia for a year. You know, I did all of my initial patients were, you know, excellent levodopa challenge, PD patients. They
Yeah.
tended to be young. There was patients in their 30s, 40s, you know, that really did really well. And that kind of, you know, launched it. So you will have a pick of people when you start a service, so that's a good thing. But yeah, it's just, you know, moving a health system, moving a hospital to, you know, get a radiographer trained that I can have on a Monday to do my spin. You know, that took many meetings.
And many emails. Thank you very much.
I have a question also for the two of you. Dr. Honey, you said you were never fellowship trained because it wasn't really something you did at that time. Nowadays, I think it's become much more established. Is it still acceptable to try to do DBS for someone who isn't fellowship trained?
You're not going to enjoy the procedure. You know, you really want to have a comfort before you're on your own. And I think that comfort comes from practice in a safe environment. So a number of the fellows from our program have gone on to do very different functional neurosurgery, but they've been confident to do it because they've got the background experience on understanding stereotactic and functional neurosurgery. So I don't think you're going to enjoy it. It's not for me to tell you not to do it, but you'd be foolish to try it without, you know, seeing it and having, I would say, a higher up the learning curve. Otherwise, you're just not going to enjoy it. And you run the risk of having a complication and then destroying your program in the first 6 cases.
Yeah, and also, how important is knowing how to do the surgery, or how much of it is knowing how to do the surgery, and how much of it do you think is all the stuff you need to know before and all the things you need to do after? Because I actually think a lot of people think if I know how to put the electrodes in the brain, I'm done.
Mm-hmm.
What's your opinion on that?
So in order to have a good outcome, you need to operate on the correct patient correctly. And so you need to be able to choose the patient. That's the difficult stuff of functional neurosurgery. The surgery is quite easy. Don't tell the aneurysm people. The surgery is very easy, but if you make a little mistake, you know, all hell breaks loose. And so, but the hard part of functional neurosurgery, the joy, the art of medicine is selecting the right patient. And that takes experience or good collaboration. Otherwise, if you don't truly understand that, you're just an expensive Rosa. I will put the lead in the right place. Thank you. Oh, back to you. We had a patient many, many years ago who went to Mexico to get their DBS, came back. They were no better because they didn't know you had to turn the device on. And so there are a lot of these outrageous but a little bit funny stories about exactly those people who have, let's say, given it a go without truly knowing the fundamental understanding behind it.
Yeah, I would agree. I try and I made time in my kind of schedule when I started that I would have clinics. So me and the neurologist sit and we do clinics together. We do the programming. I don't get to do all of them, but I do at least one a month, kind of to be like, are my leads doing what they're supposed to be doing? Yeah, and it's the fun part of it. That's the joy out of DBS is switching it on and, you know, looking at your VTA and checking, you know, seeing how the patient progresses. So I think if you're going to be the robot with, you know, a human, you know, the Rosa, just it's boring as well. And it's not as good. And the more you can be really collaborative with your neurologist and like sitting in the same room and being like, and there's been a couple that I've said, you know, they were good candidates. And I was like, they are not getting a surgery. You know, you have spidey senses as a surgeon sometimes of like someone who just is never going to get better. No, for odd psychological reasons they can't pinpoint, but very rarely, but it helps when you really sit together.
When I first began, there was no DBS nurse, and I did my own stimulation, and I learned a lot about the surgery from activating the patients postoperatively. And I learned how far off you could be and get away with it, and how I should have done something different in the OR. And so it's important for our fellows to spend time with the DBS nurses adjusting patients postoperatively. You have to select the patient correctly, do the surgery correctly, and then adjust them to optimize their outcome postoperatively. And I do think the neurosurgeon should know all aspects of that, because you become a better physician if you do.
Yeah, I absolutely agree. I think if you're just a robot and you're missing this feedback loop, you're never going to improve. And the only way of getting a better functional neurosurgeon is to see what did this electrode actually do with that patient who has these specific symptoms. And I think, again, this is something that a lot of people probably underestimate, and that you have to put that time aside and have to spend that time.
And a lot of the new tech, in terms of ADBS and the programming with the AI, Illumina, all that is all, you don't want to be behind. You want to know it.
Yeah. Do you think you can be a good functional neurosurgeon if you are not interested in research, or if you're not keeping up to date? Because there's so much happening. Does it have to be kind of part of your practice to keep your eyes open? And
traditionally, it has. Traditionally, functional neurosurgery has led the way in terms of basic science research. But no, I think if your pattern of practice doesn't allow that, our next fellow is coming from Uganda, and I doubt very much that they are going to be a research powerhouse. But I think they're going to look after patients, and I hope that they're going to look after patients very, very well. We have tried to balance, patients from Europe, Australia, Western, North America with patients from countries that don't have as much funding, and they go back and do fabulous work for their patients. And maybe it's just RF, but they're looking after people.
I think sometimes it puts people off functional neurosurgery, thinking how research heavy it can be, and people think it's too academic, I need a PhD. It's not really the case. Like Dr. Hani says, if you're looking after patients, caring about them, doing good surgery on the right people at the right time, it's very satisfying, and that's fine. There are people doing some very highbrow research and lower brow research as well, but it doesn't mean that everybody has to. Keeping up to date is key, though.
And typically, the person who's giving that lecture on functional is, Dr. PhD doing incredible research, because that's why you ask them to come. So you typically don't get the worker bees who are doing wonderful functional neurosurgery, but, don't have a high profile internationally.
They're busy.
They're busy doing good work. Yeah.
But it is a beautiful field to do research and to combine it. I think if for those out there who love research or who want to do research, I think it's a very nice field, because there's so much happening, and it's so they're so versatile. But true, you don't have to do it.
Yeah, I agree with Marie, because you can constantly be better, and you can constantly reflect yourself, and so it's a good field of research, but you don't have to, as long as you're able to reflect yourself.
Okay. I think we are coming towards the end. Any final comments from the two of you? Maybe just again, what do you want to tell people out there who are thinking about becoming functional neurosurgeons? Any good advice?
Well, you will never be bored. If you keep your eyes open, you will actually discover something that no one has seen before. just from being a good doctor, listening to your patients. And so I would be more than any other subspecialty, which can be very technical. It doesn't matter who the patient is. If they got an aneurysm, you're going to clip it. It does matter who the patients are. You need to listen to your patients and understand them if you want to ensure that your surgery will actually improve their quality of life.
Yeah.
Okay. Dr. Moran?
Yeah, I think, as Dr. Tony said, you're never going to be bored. And, the recent Huntington's treatment with delivery, disease modifying genetic meds, I think it's going to be functional neurosurgery. And I don't think that's very long away, I would hope. I think we're going to be upskilling again for a new class of treatments as functional neurosurgeons.
Okay, great. So thank you once again so much for the wonderful talks, the great discussion.
I feel like a gate crashed a reunion.
It's super nice to meet you.
You do.
Okay, I'll just hand over to Mike and Franziska to also say a few final words, and I'm going to say goodbye and thanks everyone for joining the webinar. Yeah.
Thank you.
Thank you very much.
Yeah, thanks very much, everybody. I learned heaps. I'm going to go
Have a
and
nice
service.
evening and have a nice day.
All right.
Okay.
Bye.
All right.
Bye.
Bye, everyone.
Bye-bye.
Bye-bye.
Bye.